All right, I think it's probably time to start. I hope everyone can hear me.
John, I'm going to introduce you.
Okay, my name is John Molitor, and I'm Associate Professor of Biostatistics here at Oregon State, and I think most of the participants will know me. Welcome to the Friday Research Seminar. We're glad that you could join us. We have participants here in the well, most everyone's here via Zoom. For security, we are using a webinar, which means your microphones are muted. To ask a question on Zoom, please use the Q&A feature. And this is a little new for me too, not the chat, the Q&A feature. We will be moderating it and reading them aloud so that our presenter can hear them. Okay. And now I will go ahead and introduce Dr. Ying-Ying Meng. She's the director of the UCLA Center for Health Policy Research. She is also a co-director for the Chronic Disease Program and senior research scientist at the UCLA Center for Health Policy Research. She has been a principal investigator for numerous multi-year epidemiological studies on the health effects of air pollution and the lead evaluator for intervention projects funded by federal and state agencies. In these epidemiological and intervention studies, she and her team examine relationships of social positions, neighborhood factors, and health behavior, morbidity of chronic conditions such as asthma, diabetes, and obesity. She is currently leading a 5-year statewide priority populations initiative evaluation, which is a comprehensive evaluation of the collective impact of California Department of Public Health, California Tobacco Control Program Priority Populations Initiative, focused on African American and Black, Asian Pacific Islander, Hispanic, Latino, lesbian, gay, bisexual, transgender, and queer and rural populations. She is also a principal investigator for a high impact research project studying state and local policies on smoking behaviors and disparities, and examining the interaction of individual, community, and socioeconomic factors. Meng is also a principal investigator for a study that evaluates the acute health impacts for short-term particulate matter exposure on work loss days in normal times or during and after wildfires. She has advanced expertise linking and analyzing health and environmental data to study social and physical environmental patterns of inequity. Prior to joining the center, Meng was the vice president of the Wildflowers Institute. She has worked as a senior researcher in the Quality Initiative Division of the Foundation Health Systems and as the director of programs at the Association of Asian Pacific Community Health Organizations. She also provided consultation to private government and international agencies. And on a personal note, she also has worked with me quite extensively, and it's always been really great working with her. So I will go ahead and hand it off to Dr. Meng, and please begin your presentation.
Thank you, John. And I also really want to thank your institute to invite me to present at this seminar. I really wish I could be there in person, but hopefully next time. So today I will talk about a quasi-experimental study, mainly looking at the California good moment policy impact on reduction in air pollution as well as in emergency room visit due to the this policy. I want to start the talk to thank for the funders. The project was funded by Health Effect Institute. Health Effect Institute is funded by US EPA as well as automobile industry and some private foundation and investment bank. They in return funded worldwide researchers to look at health effect of air pollution exposures. And I think this project is also possible, made it possible because the California Department of Healthcare Services provide us the Medicaid claim data. And I also want to thank the team, and because you can see that we have a multidisciplinary research team, and they come from all over the country, and Dr. John Morito is a part of the team, and he really helped a lot with the statistic modeling. And I also hope this presentation will stimulate our future collaborations and also the interest among students. And we always recruiting the young talents to join this kind of studies. So this is the part of the accountability study, and just briefly, the accountability study is the study launched by government to assess the impact of the air pollution control regulation on air quality as well as on health. And from like 1970 to 1990, EPA invested about 25 billion per year, and they want to know if those investments made a difference on air as well as on health. And based on the government monitoring data, the impact on health on the air is relatively easy to detect, but the impact on health, on the exposure and the health, it's not easy to do. So this is the one of the study try to do that. And we, as mentioned, that it's a experimental, quasi-experimental study design. We have created a retrospective cohort, about 23 Medicaid beneficiaries from 2004 to 2020. And they are all the Medicaid beneficiaries, so mostly low income, and they are 22 and older, mostly under the 65 years old, because if they are reach the age of 65, they will be qualified for Medicare, so they were excluded from the study. And then they will have at least one of the 4 diseases, asthma, heart disease, COPD, and diabetes. So this is a very good studies group to really examine the reduction in air pollution from good movement action and the subsequent improvement in health for the disadvantaged population. Previous study have established the biological link between air pollution exposure and the health. So when we breathe in the bad air, it creates the pulmonary oxidative stress and inflammation. And when this air enters our bloodstream, it also causes the systematic stress, oxidative stress and inflammation in different organs of the body. And then why California needs good movement regulation? Because about 40% of the goods move in and out of the US are through the ports of California. California had several major ports. And when the ocean-going ships, entering the port, they, we need a cargo handling equipment to move those goods to the truck and to the train, and then the train, also the trucks move the goods to the local warehouse as well as to their destination market. So all these equipment use the diesel engine, and so along the way they created lots of pollutants. So in 2006, the California Air Resource Board and the local air quality management districts approved the Emission Reduction Plan for ports and the goods movement. There were about 200 actions with an estimated cost of 6 billion to 10 billion. And the strategy, as usual, including some regulatory actions, some incentive programs, as well as the lease of the equipment, and also the agreements between the different entities, or trading the old equipment with the new equipment. So some example of such strategy is that they require all the ocean-going ships to use the electric shore power once they reach the dock. And also, they ask one thing I should have mentioned, that all these all this equipment handling these goods movement are mostly private owned. So to some degree that the government need to also provide some incentive to make things happen. And so they do, like for instance, they give a truck company or truck owner some incentives to retrofitting their engine. And at the same time, they also have a regulation, say, to a certain date, that if your engine is like 20 years old, you are not allowed to enter those ports. And so all these actions has a goal to reduce the statewide emission back to the 201 level by the year 2010, and also to reduce the statewide diesel particulate matter health risk, such as cancer risk, by 85% by the year 2020. And then also, because the South Coast L Basin has two major ports, the Long Beach and the LA port. So they require the reduction of nitrogen oxide emission by 30% from the 2015 level, and the 50% from the projected 2020 level. So our study area covers 10 counties. It also included 4 major ports: Los Angeles, Long Beach, Oakland, Stockton, and San Diego. To do a quasi-experimental study, we divided our study area into 3 areas. First, we call the goods movement corridors, mainly the port areas, and also truck dominant freeways. And then we also have a non-goods movement corridor. It's mainly the car dominant freeways. And so within the 500 meters of car dominant freeways. And the control areas are mainly the residential areas. And California has a pretty good air monitoring system. For instance, it has a 142 monitoring station for the NO2 and the NO for the NOx, but they are still not densely enough. So we did our own deployment of the Aurora monitors in 2012 and 23, and also use the previous. We also have access to the previous monitoring. So we do have for the same site, we do have a pre and a post monitoring data. So since our study area, our study period is from 2004 to 2010. So it was just the economic downturn was during our study period. So we need to assess if the reduction of air pollution is due to the economic downturn, or it's due to the actions. And so this first line is the curve of cargo volume. And so this, you can see, this could be a proxy of economic downturn. So you can see there was a downward trend of the cargo import and export during 2009, and then it went back to the in 2012. And but at the same time, based on the government monitoring data, the pollutants were going down. And so we did publish this paper and show that due to the goods movement regulation, air quality in goods movement corridors in California improved. California Air Resource Board estimated that for every $1 invested in cleaning up the pollution from goods movement actions, $3 to $8 in healthcare costs will be saved. And so our study is trying to see if that's true. But we use the, as I mentioned before, we use the Medicaid enrollment data and for the study period. The data included age, gender, race, ethnicity, language speaking, disability status, and the state of service, as well as the what kind of service provided and the disease treated, and also the medication dispersed, and there's also the charge. And the best of all is that we have enrollees' home address, so that will allow us to very accurately to assign the beneficiary to the appropriate corridors. So use the claim data, mainly the ICD-9 codes, as well as the type of claim and the place of service. We define two major outcome measures. One is the annual emergency room visit, and the other one is the annual hospital admission. That they are all the actual counts. I think you may all know it's very important to control for the time varying covariates, because our study period is 6 years, and they all have the subjects all have chronic conditions, so their disease may be progressed. So we need to control for the progression of their disease severity, and we also control for the number of comorbidities. So we use if the subject has records of comorbidity pre-policy, we treat them as having a comorbidity. For instance, someone has asthma, also has a diagnostics of heart disease, then that person has heart disease as comorbidity. And if not, but it show up in the post-policy period, we will define them as having developed a new comorbidity. And then since our outcomes is for ED visits and hospitalization, some of the emergency room visit and hospitalization could be prevented if you have access to appropriate primary care. So we use the year-specific number of primary doctor visits as the proxy for access to primary care. And then some of the health behavior like smoking or other like a mental health will affect their disease progression as well. So we also control for using the ICD-9 codes to identify smoking and the depression status and a control for them in our analysis. So before we do the health effect study, we use the land use regression model, developed the pollutant surface. And so based on the land use regression model for the total vehicle miles traveled and the total truck kilometers traveled had a positive impact on NO2, but the vegetation had a negative impact on NO2. And as well as, the open space and the water body, for instance, if you have a lake nearby, it will also have a negative association with NO2 concentration. And we also did the same similar surface for the PM 2.5, and all the factors has a relationship with the PM 2.5 are similar with the NO2s. So using the pollutant surface plus the medical claim data, we created our study sample. We started with about 70,000 beneficiaries. They will have at least one of the 4 chronic conditions. And then we confine this, restrict the study sample further to those with continuous enrollment. So that really reduced sample in more than half. And then we require them to have a valid address. So if they have a PO box or zip code only information, we exclude them in our study sample. And then we require them to have at least one claim in all the 6 years. So which means, sometimes the people disenroll, but it may not show up in the system. But if we assure that we require them to have at least one claim, so we can assure they have a continuous enrollment. And then they need to have a valid corridor assignment and the pollutant assignment. So with the combined data, we can see the exposure of beneficiary for NO2 and the PM 2.5 were reduced. And so the red line is those in the Guzman corridor, and the gray line was those in the non-Guzman corridor, and then the blue line is those in the control. So NO2 and the PM 2.5 have a very similar trend, but the ozone has the opposite. So those, in other words, like those in the Guzman corridor had a lower exposure, and also it didn't change whole a lot. But those findings were consistent with the previous study, show that the usually ozone in the NO2 has the inverse relationship. And so this is the descriptive data showing the characteristics of study population by corridors. In general, they are similar, except that those in the control area, there's a lower percentage of people with who are African American, and a higher percentage of those with who are Asian Pacific Islanders, and also low percentage of those who are Latinos. Otherwise, they are pretty similar. Also, for the, like the time varying covariates, pre and post, they are also similar. In addition to the individual level characteristics we mentioned before, we also control for the neighborhood variable, because we believe it might be important to see if the neighborhood characteristic have an impact on the healthcare seeking behavior. And so using the CDC developed social vulnerability index, we found that the people in the control area has a high, high SES status. In other words, they have a low percentage of people with below poverty, and also a small percentage of who are minority, as well as the lower percentage of people, households without vehicles. Given we have a pre-data as well as the intervention in the control or in or exposed or control group data. So we use the difference in difference model with the parallel assumption to test if the policy made a difference in different study domain. So this is the results. The red line is observed trend for those in the control, and the blue line is the observed line for those in the intervention area, the goods movement corridors, and the gray dotted line is the hypothetical line. It's mainly assume the people in the intervention area will follow, will have a parallel trend with those in the control. So you can see that for both patients with COPD or asthma, those in the control area, in the intervention area had a great reduction in NO2 exposures. So this is the regression results. And you can see that for all the people with different type of disease, they all have a reduction in NO2 exposures. And the reduction is the biggest in the year 1, and it reduced gradually by year. And all these model control for like age, gender, race, ethnicity, all the variable I mentioned before. And so this part is showing the ED visits. So it's the same the parallel assumption, and you can see that the people in the goods movement corridor had a great reduction in ED visits for both COPD and asthma patients. And this reduction can be interpreted as like 170 less ED visits per 1,000 beneficiaries. And we also did a propensity score matching. We matched the intervention and the control group based on their baseline characteristics, including age, gender, number of comorbidity, and also their disease severity. And the results, the difference in different estimate results are very similar. So the summary is that the seemed to be that the growth movement regulation made a difference on NO2 concentration, as well as had a reduction on people's exposure. And also those reduction has an effect on the reduction of ED visits, especially for those with asthma and COPD. So this results demonstrate that the action to reduce emission related to goods movement corridor is effective in improving local air quality level and also healthcare utilization among disadvantaged population. And also, since both people in both control and intervention group are all Medicaid enrollee, and to start with, those in the control area always have are in a better position to start with, but after this intervention, their exposure as well as the ED visit rate getting close to each other. So the strength of this study is that we build an annual land use regression model to associate the pollution exposure with the health outcome. We also use the longitudinal data to create a static cohort with to examine the effects of air pollution. And then because the Medicaid claim data, we can count for several common risk factors as well as the modifying factors, while we examine the relationship between air quality improvement and the decrease of adverse health outcome. And also we use the more modern and forward-thinking statistic approach for accountability study, especially included a quasi-experimental design with well-defined intervention in the control group. There's several limitations of this study. First is that I need to mention is that we only have 2 diagnostic codes for each encounter. So we might not have whole complete picture of the comorbidities. And the second is that we only have the beneficiary's address at the beginning of the study. So we might not accurately capture the exposure of those who moved. And we also relied on the residence-based air pollution exposure. So we are lacking the information on the indoor exposure as well as work location related exposures. But this, our findings do have some implications. Is that first is that it does show the addressing the environment determinants of health, such as air quality, is possibly an effective way to improve health and reduce expensive healthcare, because we all know ED visits are very expensive. And usually the Medicaid enrollee tends to go to the emergency department due to the lack of access to primary care. And then also this study findings show that the reduction of air pollution can help reduce the expensive medical utilization. And so that support further regulatory action on pollution control. And then another implication is that since we use mostly the routinely corrected pollutant and the claim data, so this investigation really contribute to the scientific methods for using these routinely corrected data for assessing long-term effect. So in conclusion, this study could be one of the very first one to show the California Resource Board Emission Reduction Plan for goods movement has not only improved air quality, but also improved health, especially for those at risk and disadvantaged population. This finding also shed a light on eliminating health inequality by reducing unequal exposure to environmental hazards. And so the finding could also help to guide other country or other states to look into a similar policy, as well as the similar study to see the impact on air pollution reduction on health. So I want to thank you, and please let me know if you have any questions.
Okay, thank you, Dr. Meng, for that wonderful presentation. I am now going to moderate the questions using this new to me Q&A feature. And I will read the questions and allow Dr. Meng an opportunity to respond. Okay, so Perry, as we all know Perry, thank you for this great presentation, exclamation point. Did you explore the use of a negative control in these models? This seems to be coming up more in air pollution epi these days.
Oh, so John is really the expert on the team, and John, maybe you should respond to that question.
Well, maybe Perry, you could elaborate a bit on what you mean when you say a negative control. We did obviously have a control group. We did make parallel trends assumptions like we're doing in your project. An outcome that should not be related to air pollution. No, we haven't done that. An outcome that, that shouldn't be related to air pollution. Yeah, we haven't done that. That's something to look into. Yeah, we haven't looked at a control other than the outcome that is related to air pollution. We did adjust for a number of different confounders as well, but that would be something that could be a sensitivity analysis that could be done. Whoop, there might be more down here. It can get challenging as everything seems to be related to air pollution these days. Yes, it would be challenging to come up with an outcome that's air pollution independent. Again, we didn't do that, but that's a good question. So we haven't done it, but worth a try. And no one actually asked for it, including in our publication explorations. It never came up, but it's a good question. Are there any other questions? Any other? We got a whole bunch of participants. I just want to, as long as we have a little time, I just want to thank Ying-Ying for doing a great job. One of the things, and I've discussed this with Perry in his project, where we're doing a lot of difference, that I distributed this paper about covariates and random effects and how that affects the parallel trends, and it's more complicated than I think a lot of people realize. But the line that difference in difference modeling contains a host of strong unverifiable assumptions, and that's quite true, that you're assuming this control treatment relationship that you observe in the pre-treatment phase will continue after policy is implemented. And you can't completely verify that through math alone. You have to use substantive thinking. And so this whole quasi-experimental design work is a combination of math and substantive knowledge. And one great thing about Ying-Ying is she, though it's not a statistician in quotes, she was heavily engaged in the modeling. And that's exactly what you need when you do these kind of studies. You can't have a substantive researcher here and statisticians here. You need people to work together to make sure the assumptions are reasonable and sensible from a substantive point of view. So I want to congratulate Ying-Ying on being so engaged in the modeling and not taking a hands-off approach. It was really wonderful to work with her on this project from an analytical perspective. Perry, were you able to measure traffic volume change? And what change is attributed to good movements, regulatory or policy changes? Ying-Ying, do you want to address that?
Oh, the traffic volume. Yeah, so we got the traffic volume counts from California Transportation Department. And so we do have actual counts, and surely during the economic downturn, the traffic volume may decrease, and but in general, the traffic volume were increasing, and then with the increase of the traffic volume, but decreasing in the emission as well as the pollutants, that's a good indicator that these regulations are working.
One other thing, Perry, I'll say that was challenging, is kind of related to this question of attribution, attributing certain things to policy changes. Mediation and difference and how to fold them all together is something we're still investigating. It seems to be an ongoing area. There is the question that policy affects, say, NO2, and NO2 affects health. But to what extent does the policy affect health through NO2 reductions, and to what extent does policy affect health directly? But how, there's mediation analysis, there's difference, how to, in a statistically coherent way, blend the two together. We're still looking into that. So that's kind of related to what you're asking about. What change was attributed to regulatory or policy changes. So direct and indirect effects, and how to link them with difference is still something. Yep, totally. Perry says, yep, totally. Yeah, that's how to blend it. You can kind of slap things around, but how to blend them together in a statistically coherent way is something we're still looking into, and it may be a topic of a methodological piece of work that we develop, but we were talking about that, but we haven't done that yet. So but good question. Yep, totally, exclamation point. So we're on the same page there.
Yeah, you know, this project, I think it's a interesting project in many ways. That the first is, you know, like I mentioned, the accountability study for the last two link, like you know, L pollution improvement, whether that will lead to the exposure reduction as well as the improvement in health. It's that last two link are still need more study are needed. And then also since I work with John, you know, John is a very rigid statistician and a methodologist. And so we do feel like it's a methodologically very challenged to, you know, to really show the difference. And there's still a lot of work need to be done. And
yeah, the whole causal modeling thing is such a big area, and Francesca Dominici at Harvard is pushing for this, and not just do association studies, but to try to really go in the direction of causal modeling. And
right.
we're looking at causally, you know, it does do the policy effects very spatially, and that's something we're working on. And of course, with Perry's project, we talked about that as well. And I've got some ideas on how to look at that. But that's, you know, that's another big area, you know, using the difference in difference framework and combining with all these other type of methodologies from an analytical point of view is, I think, just fascinating. But anyway, so yeah, it's a lot of fun stuff there.
Yeah.
Perry's got a great project, Ying-Ying, by the way, we're working on. It's very exciting. So highly relevant to what we did with you.
Oh, that's great.
Highly relevant. So fun project. I just want to thank Dr. Meng for a wonderful presentation and for giving me the opportunity to work with her over the years. And wish she'd be here, but I hope she will be here in the future to see Oregon, which we all love.